Now, what we're going to do today is just a cranial nerve examination, and I'll start up at the top and move down in terms of reflexes and strength and coordination. So the first thing I want you to do, first of all, is just square yourself off, knees back on the edge of the table, back farther. So your legs are dangling. Okay, good. Nice and square all the way so that you're looking straight at my nose. And what I want you to do is just point with your hands to the fingers that you see wiggle, but keep staring at my nose the whole time. Okay, good. Now, watch my finger wherever it goes, holding your head still the whole time. Okay, good. I'm going to touch your forehead and your face. You tell me if you can feel it the same on both sides. It's about the same?
Yeah.
Equally? Even in here where that injury was before?
Yeah.
Or is it a little numb there?
The other side head?
Well, remember the second one, you had that cut right in here.
Oh, that's right.
Can you feel there?
Yeah.
Oh, so that's all back to normal now. That's good too. Close your eyes real tight. Real tight, like you got soap in them. Don't let me open them up. Fight, 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 fight. Okay, good. Wrinkle up your forehead like that. Good. Show me your teeth like this. Okay, good. Open real wide. Say ah.
Ah.
Okay, stick out your tongue. Okay, good. Clench your teeth. Again. Okay, that's good. I'm going to make soft noises next to your ears. Close your eyes and tell me left or right.
Right. Left. Both.
Okay, that's good. Shrug your shoulders. Like this. Okay. Turn your head as far as it'll go to the left and hold it there. Okay, now to the right. Forward and back. Okay. No problems that way with that at all. Okay, good. With your hands, hold them out in front of you like this, stretched all the way out like you have a board. Now close your eyes and hold them nice and steady. I'm going to tap your hands. Don't let them move. Keep your eyes closed and touch your nose with this finger. Okay, and now with this one. Okay, perfect. Just relax and open your eyes. With your right hand, do this like I'm doing it real fast. Right on that knuckle. Very good. Left hand. Okay, very good. Now do this. And the other hand. Very good. Now here on this knee, do this. And there. Okay, good. Touch my finger with yours, and then touch your nose. Go back and forth wherever I move my finger. Very good. Now left hand. Okay, that's great. Hold your arms up like this and don't let me push them down. Fight real hard. Okay, good. Make muscles like this and don't let me pull them out. Fight. Okay, same idea. Fight. Okay, same position. This time, push out. Okay. Okay, good. Now, stiff wrists back like this and don't let me bend them. Okay. All right, very good. Grip my hands. Very good. Fingers spread apart and don't let me squeeze them together. Fight real hard. Fight real hard. Fingers back like this and don't let me push them down. Don't let me push them down. Okay, that's really good. Now, with one knee at a time, I'm going to have you lift it up and not let me push it down. So just pick this leg up. Fight. Okay, this one. Okay, very good. Push your knees out against my hands. Okay, and pull them in. Okay, now kick out. Okay, now kick out. Okay, and now pull back. Don't let me pull it in. There we go. There you go. Pull it. Okay, very good. Now, feet up in the air like this and don't let me push down. Okay, and this one. Same thing. Okay, very good. Now, if we did that right, the doctor and the patient are supposed to get red in the face, but I suspect only I got red in the face this time. There. Scoot back just a little bit so your shoes aren't quite out. There you go. Perfect. Just like that, nice and loose. Okay, good. Now, stare at the edge of that picture and don't blink as I tap your forehead just with my finger. Keep staring there. Okay, now, here, feel this first, Pat. It's a little bit, it's not sharp, but it's rough, right? I'm gonna stroke your palm like that. Look at that. Don't pay any attention to what I'm doing. Same thing here. Same thing here. Okay, good. Now, I'm gonna tap my finger. Just let your jaw hang. Just like that. Okay, very good. Cool metal, yes, cool.
Mm-hmm.
Same?
Mm-hmm.
Here, and here, about the same?
About the same.
Here, about the same?
Mm-hmm.
Here and here, about the same?
Yeah.
Okay, here.
Mm-hmm.
Okay, and now, what I'm gonna do down here is I'm gonna put this on your ankle and you can tell me, what do you feel now?
Vibration.
Okay, tell me when it's completely gone, look away.
Gone.
This one? Same idea, feel it?
Yep. Gone.
Okay. The rest of what we would do in terms of pinprick and all that, I'm not going to go through today because I know that's all been normal all along, and I wouldn't anticipate that to be a problem. I do want to look in your eyes. You still have just a little bit of a lid lag on your left since that blow to your brow.
Remember when
Have
you first
noticed
saw
that?
me about the right side of my eye? I think that was always there. But you mean right
It
here
was your
now?
face.
That was my right side of my
Yeah, it was, but it was down. It was here.
Yeah.
And then what we did is that you gave me that videotape of
And
the
confirmed.
pre-injury, that it was always, it's just the way your face has been all your life.
It's the way it is.
Yeah. So what I want you to do now is just stare again at that spot. Blink anytime you need to, but keep staring at one spot. I apologize for my sandwich breath here. Very good. Looks great. Any problems with your hearing? I surely didn't detect anything. Any problems with wax buildup or anything I should look in there?
Okay.
Right, you're good. But what I'm speaking of really has to do with the opening of this eye compared to this one. This one still is down a little bit because of all that injury right here.
Yeah.
From your last concussion.
That's where I had all the redness for
You
the
sure did.
longest time.
It half closed your eye.
For a long
For the
time.
longest time. And so now I think that the control of that lid is still impeded a little bit.
Really?
By the soft tissues that are coming down on it.
Okay.
And it's just minimal. I don't think it's a neurological issue at all.
It's just a cosmetic thing.
Yeah. Well, and probably isn't noticeable to anybody other than those of us who examine you and look
Yeah.
for these sorts of things.
Because I don't even notice it.
Yeah. Yeah, it looks fine. Everything else looks just like it has before. Just perfectly fine. No problems. No concern.
All right. Hi, Megan. Tom.
Hi.
Nice to meet you. All right. So we're going to start just like any regular ophthalmology exam with our core 5: vision, pressure, pupils, motility, and visual fields. Okay. So do me a favor. Cover your left eye with your left hand. And I'm just making sure that she isn't cheating and that her hand's totally covering her eye. If you have an occluder available, that's also an easy way to do it. Okay, so just with your right eye, tell me what the smallest line is that you can see on the chart. Very good. Okay, and now switch. And now same thing with the left eye. Good. Okay, so if a patient is able to see 20/40 or better, we kind of let it go at that. If they're seeing less than 20/40, excuse me, I'll use the pinhole occluder to see if there's a refractive error involved. Next thing I'm going to do is check your pupils, okay? So I have a very bright light, I apologize. So I'm going to have the patient focus at distance so that we're not inducing an accommodative reflex and creating pupillary constriction. So the gray light switch, do your best to just stay focused on the gray light switch. Try not to switch to me and focus on the light, okay? So just kind of try to focus on staring off into the distance. And like with any pupil exam, I'm looking at the eye that I'm shining the light in, but as importantly, I'm looking at the eye that I'm not shining the light in, making sure there's symmetry, no afferent pupillary defects, or problems with constriction or dilation. Normal pupil exam, you're doing great. All right, so now we're going to check your visual fields. So do me a favor, cover your left eye with your left hand. Same thing, I'm going to make sure that her hand is completely occluding the eye we're not testing. And then I'm going to line up so that our faces are exactly facing each other, our noses are lined up. And then I'm going to close the eye that is the mirror image of her occluded eye. Okay, Meg, now look right here at my nose, and I'm going to hold my hands up, and you're going to notice I always hold up two hands. A patient's natural tendency is if you put up one hand, they're going to move their eye to look at that hand, and that can give you a false reading because that's sort of a way for them to cheat because they see the quick movement and they focus, and then they see what fingers you're holding. So by holding up two hands, it kind of forces them to stay straight ahead and focused. So you're doing great. Look right at my nose and tell me how many fingers I hold up.
2, 5, 1, 2, 1, 5, 2.
Perfect. Okay, switch eyes for me. Okay, and same thing, look right here at my nose. I usually give them a second to adjust to the light because that eye's been closed for a minute. Okay, keep looking right at my nose, you're doing great. How many fingers?
1, 2, 5, 1, 2, 2.
Perfect. All right, very, very good. All right. Next, we're gonna check for motility. I like to use a muscle light with my finger on it. It's just an easy target for both adults and children to follow. So, Meg, do me a favor, keep your head very still, and just with your eyes, I want you to follow my finger, okay? Okay, so look, and we're checking all positions of gaze. And it's okay, I'm just gonna gently lift your eyelids up. And so what I'm gonna do here is just to make sure that they can move their eyes all the way down, I'm gonna hold the upper eyelids up just so I can get a really good view. You're doing fantastic. Next thing we're gonna do is check the intraocular pressure. So whatever device you have available to you, use it. There's another good video that will be published using the Goldman applanation. If I have one available, I like to use a tono pen, especially because as part of an orbital exam, I like to check the intraocular pressure in different positions of gaze. That's very important with things like thyroid eye disease and fractures because if an orbit's very congested or there's an entrapped muscle, the pressure will oftentimes rise in the eye when they go off of central gaze. So, for example, with thyroid eye disease, I always check with the patient in primary gaze and then with up gaze. And if there's a significant difference between those two, that makes me more worried about a congested orbit. Okay, so obviously put numbing drops in. We're not actually going to check Meg's pressure, but I have her look straight ahead. And then the other reason I like to use the tono pen is because you can sneak it in between the eyelids. So even if they're coming in with a swollen eyelid because they've had a trauma, you can oftentimes still check the pressure on the cornea without having to open the eyelids up. The reason I worry about that is if they have a lot of edema in their eyelids and you open it up to check the pressure, you're going to artificially increase the orbital pressure while you're checking it. So just try that sometimes. If you have a tono pen, you're doing a trauma eval on a swollen lid, check it with the eyes open and then check it with trying to just get into the palpebral aperture, and you might be surprised at what a big jump occurs when you are mechanically elevating the eyelids, okay? All right. the other things we're going to check with an orbital exam, I want to check to make sure that the optic nerve is functioning well. So this test is called red desaturation. Pick up the brightest, reddest object you can find, often the tip of a phenylephrine or a tropicamide cap. One of the red dilating caps is what works really well for me. Okay, so what color is the cap on that pen?
Red.
Okay, and what color is the cap on that pen?
Red.
Is that the same color red between both eyes?
Yes.
Okay, now I want you to look straight ahead at that light switch again. And I'm going to bring this pen in from the side. Tell me if that pen looks any brighter or darker on one side versus the other. Okay, good. So that's checking for red desaturation. I'm also going to check for brightness desaturation. So again, I'm going to have the patient focus ahead. So look at that light switch again for me. I'm going to shine that bright light in your eyes again. I apologize. And now I want you to tell me is that as bright as that?
Yes.
Okay. If the patient's to say no, it's dim in one eye versus the other, there's a couple ways to kind of try to figure out how much loss there is. It's a subjective test, but I like to say things like, okay, if her right eye is the one where she says it was dim in that eye, say, okay, if that's 100% brightness, what percentage of brightness is that? And they'll give you a number like 75% or 50%, and that's just a way subjectively to check it over time, okay? All right, so moving on to an orbital exam, I want to check your eyes to see if one eye is farther forward than the other, okay? So we're going to use an exophthalmometer so that we can measure for relative proptosis or enophthalmos, okay? This works very well if a patient has normal bony structure. This can be sort of a confusing test if they have fractures or facial deformities. But essentially what you're going to do is the curves of the exophthalmometer, I want these curves to rest right inside the lateral orbital rim. And I try to use a target of the lateral canthal angle where that comes together, where that hooks into the lateral orbital rim. That's going to be the points that I'm shooting for. Okay, this can cause a little bit of a pressure sensation for a patient. It shouldn't be sharp, but especially if they have fractures or they're swollen, it can be a challenging exam. But do your best to try to get bony contact with the exophthalmometer so that you have accurate readings. Okay, so look straight ahead for me again, Meg. I'm going to bring these guys in. I'll be as gentle as I can. Perfect. So you can see I'm right at those lateral canthal angles. I'm parallel to the floor. Okay, and then open up really wide for me. And then what I'm doing is lining up the two red lines that you see in there. You want to move your head until those two lines that are sitting on top of each other. That's your 18 millimeter mark. And then you're looking at where the cornea sits on the scale that you see in the prism. And as long as your red marks are aligned, you're square. Okay, so the red line doesn't mean anything except that that's where they happen to place it at 18 millimeters, and you're worried about where the pupil is then sitting on that millimeter scale. If you have them available, I like to use loops because I feel I can get half millimeter increment readings from the exophthalmometer when I'm wearing my loops. Okay, and then really what's important with an exophthalmometer is that the same person is measuring it to get the same results. Okay, so I might get a different base than another doctor, but it's more important for me in my records that I keep my base the same, and then I can kind of track changes that way. Okay, all right, the next thing I want to do is gently press on your eyes. Okay, so in an orbital exam, you also want to check for retropulsion. Now that's really important if you have a trauma patient, you're worried about a retrobulbar hemorrhage. You have a thyroid patient, you're worried about a congested orbit, or you have any sort of an orbital tumor and you want to make sure that there isn't congestion in the orbit. Okay, so gently close your eyes for me. And then just with my thumbs, I'm just going to gently press on the eyes. And you'll be surprised at how sensitive your thumbs will be in picking up differences in pressure. And if there's a retrobulbar hemorrhage, it'll be as firm as a rock. If there's a tumor, it should be harder to press in. The same thing with thyroid eye disease. It's a good base measurement, and it's also a good way to track changes over time. So you didn't have any difficulties with retropulsion. So far right now your orbital exam is perfect. All right. So moving on to sort of a fracture exam or a trauma patient, we're going to check to make sure that the bony rims are intact. Okay, so again with my thumbs, I'm going to start at the superior orbital rims, feeling for crepitus over the nasal bridge. Okay, and then I'm going to go from here to the superior orbital rims. And I'm just going to move my thumbs out. I like to do it at the same time on both sides so that I can appreciate if there is a difference. A lot of times you can feel a supraorbital notch, or somebody will have unique or frontozygomatic sutures that are easier to palpate, but if it's the same between both, obviously it's less concerning. I do pay special attention to the frontozygomatic suture region because that's a weak point, and oftentimes with ZMC or tripod type fractures, you'll feel displacement in that area. And I work around to the lateral canthus, and then I come down across the medial rim. And again, just palpating and feeling for any step-offs or irregularities in the contour. Okay, so that's great. I don't feel any problems there. Next thing we're going to do is check your facial sensation. Okay, so we want to look for V1, V2, V3, make sure that those are all intact and symmetric. So I'm just going to lightly touch your skin. I want you to tell me if that feels the same on both sides, okay?
Yes.
Feels the same, good.
Yes.
Okay, so here I check the V1 distribution, V2, and then V3. Does that feel the same?
Yes.
Perfect. Okay, so far everything's looking really good. Now I want to check for facial strength to see if there was any facial nerve injuries. So lift your eyebrows as big as you can for me. Scrunch those down, good. And now squeeze your eyes as tight as you possibly can and don't let me open them, okay? Good, she has good healthy strength. So that's important for traumas, for strokes, and also very important when you're doing an eyelid surgery evaluation. A lot of people have had Bell's palsy and it's resolved over time by appearances, but when you check the orbicularis strength, you might find that it's decreased significantly compared to the unaffected side. And that's something good to know before you do a blepharoplasty surgery to make sure you're not going to induce any lag ophthalmos postoperatively. Okay? And then I want you to do me a favor, clench your teeth like that. Does your jaw feel aligned? Mm-hmm. Okay. Any pain when you bite down on your jaw? Mm-mm. No? Okay. All right, and so when I'm doing a facial fracture exam, I'm also going to check for instability or movement in the maxilla. So excuse me 1 second while I put on a glove. Okay, and I'm going to put my gloved hand in your mouth, and I'm going to go on either side of your upper teeth, and I want to see if there's any mobility in your mid-face region, okay? Okay, so I'm going to gently put my gloved hand inside of the patient's mouth. I'm going to go on either side of the upper teeth, and I'm just basically gently wiggling the maxilla back and forth. If there's a lot of instability, you'll feel it, and that will help guide your surgical decision making and also be a reminder for you to make sure that the patient follows a soft diet so that they don't induce further instability until we have a chance for the fractures to heal. Okay, so far everything's looking good. The one other test that we want to really do with an orbital patient, especially if there's concern for an orbital tumor and you want to see if it's vascular or not, there are two things we want to do. One, we want to listen for a bruit, so we're going to auscultate with a stethoscope. Two, we want to check for increased proptosis with Valsalva type maneuvers, as that will push the eye forward with the Valsalva, which will help sort of lead you down one differential diagnosis path. All right, so with the stethoscope, you're actually going to put the stethoscope over a closed eyelid and then listen. And if you hear a bruit, it's a very concerning finding and you want to get imaging as soon as possible, okay? Okay, gently close your eyes for me. Perfect. Good. Very good. Okay, no bruits. All right, and now we want to check the exophthalmometer post-Valsalva. So you want to set your base back to where it was. Hers was at 101. Okay, Meg, here's what I want you to do. I want you to pinch your nose, and then I'm going to have you lean forward and pretend like you're blowing up a balloon or trying to make your ears pop. Basically what I want to do, I want to see your face get red. Okay, so that will mean that we're building up a lot of vascular pressure in your face, okay? So lean over and then blow out and really bear down, use your stomach and everything, so you see her face is turning red. That's perfect. If they'll tolerate, I'll have them do it for up to 20 seconds. I have my exophthalmometer ready to go and have them look straight ahead. I'm going to put it right back, and I'm going to look at the eye that I'm worried about first. Okay, and look straight ahead. I want the center of that cornea right on the line, making sure I'm parallel to the floor. Good. Okay, and there's no increase in proptosis or change in the measurement, so you're doing great.
Okay, can I get you to just put your arms up like that for me? And close your eyes. Okay, and if you just turn your palms around the other way. Okay, that's great. And just relax for me. Just going to have a closer look at you. Okay, now I want you to go lovely and floppy. I'm just going to move your arms for you. Okay, and relax. Okay, great. Right, can I get you to put your arms up like that for me? And stop me pushing you down. Brilliant. Push down into my arms. Okay, and relax that arm. Bend your elbow. Now push me away and pull me towards you. Brilliant. Do exactly the same with this side. So push me away and pull me towards you. Okay. Squeeze my fingers nice and tightly. Okay, and relax. Now, can you get you to cock your wrists up like that for me? And stop me pushing you down. Stop me pushing you down. And if you cock them down, and stop me pushing you up. Stop me pushing you up. Put your fingers like that for me. And stop me bending them. Stop me bending them. Okay. Spread them out like that. Stop me pushing them in. Stop me pushing them in. Okay. Now, can you get your hands like that? So your palms up, your thumbs up like that. Brilliant. And stop me pushing you down. Okay. Just going to use a piece of paper. Can I get you to put your fingers like that for me? I'm just going to put that into your fingers. Just open it up. And try and stop me. Brilliant. And the same on the other side. Stop me. Okay. You get your little finger and your thumb together. Yep. And stop me out. Brilliant. Okay. Great. So that's all your power done. Just going to test your coordination if that's okay. Can I get you to place your palm up like this? And if you slap it with your hand like that, if you copy me. And just keep doing it. So palm. Yep. Brilliant. Have you swap hands? Do exactly the same. Okay, and relax. Now, using your index finger, I want you to touch your nose and then touch my finger, and I'm going to keep moving it. So if you use this finger and touch your nose, then my finger, and keep doing it. Okay, brilliant. Swap hands, do exactly the same with the other. Okay, excellent. So that's done for coordination. So I'm just going to test your reflexes now. So I still want you to go lovely and floppy, and I'm just going to use this. It doesn't hurt. So try and relax. Same the other side. Okay, and relax. Okay, brilliant. Now I'm going to test for sensation. So Can you feel this cotton wool there?
Yes.
It's all soft. Okay, I'm just going to get your arms in the right position and just open them out. Okay, say yes when you feel it.
Yes. 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 Yes.
Brilliant. Okay. Now, I'm going to test pinprick. Now, I know it sounds a bit scary. It's a pin. It does feel quite sharp, but it doesn't break the skin. So you can feel that there.
Yes.
So you feel it's different to the other one. So again, I want you to close your eyes and say yes when you feel it.
Yes. 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 Yes.
Okay. Now I'm just going to test vibration sense. So can you feel it vibrating? Not the pressure, just the vibration.
Yes.
And see, and then it stops. So I want you to tell me if you feel the vibration, not that you feel the pressure. Okay. So I'm just going to get on the corner of your finger first of all. You close your eyes. Can you feel that?
Yes.
Brilliant. Tell me when it stops.
No.
Okay. I'll do the same again. Can you feel that?
Yes.
Tell me when it stops.
No.
Brilliant. Okay. Can you feel that?
Yes.
Tell me when it stops.
No.
And again. Can you feel that?
Yes.
Tell me when it stops.
No.
Brilliant. Okay. Now, I'm going to try and test for whether you can say where your joint is in. What I'm going to do is you can keep your eyes open first of all. It's holding that. I'm going to move your finger up or down. And I'm wanting you to tell me whether your finger's up or down. Okay. So close your eyes.
Down. Up. Down.
Okay, that's brilliant. And we'll do exactly the same on the other side. I'm just going to hold your finger so you can open your eyes again. So I'm going to move it up or down. So you tell me which way.
Up. Down.
Okay, brilliant.
And I'm now going to show you an examination of the hands. This follows the normal pattern of look, feel, move, but the hand should not be considered alone. It is part of the upper limb and should be considered in conjunction with the neck, the shoulder, the elbow and the wrist. Having screened the neck and the shoulder, I would begin at the elbow. I look for any signs of psoriasis or rheumatoid nodules. I would then move on to the hands. I would begin by assessing from proximal to distal, looking at the dorsal aspect and then moving on to the volar aspect of the hand. Look for any deformity at the wrist, the metacarpophalangeal joints, the proximal interphalangeal joints and the distal interphalangeal joints. I also look for any scars, the condition of the nails, particularly for pitting and psoriasis, for any soft tissue swelling, for signs of a boutonniere deformity, where there is flexion at the proximal interphalangeal joint and hyperextension at the distal interphalangeal joint, a swan neck deformity, where there can be hyperextension deformity of the proximal interphalangeal joint and flexion of the distal interphalangeal joint, for signs on the volar aspect of Dupuytren's disease, for shouldering at the first carpometacarpal joint, and wasting of the thenar, the hypothenar, or the intrinsic area at the dorsum of the hand. We will now move on to feel, and we will go, as usual, from proximal to distal. I assess the wrist first, feeling the radial styloid and the ulnar styloid. Between these is the wrist joint. Here is the triangular fibrocartilaginous complex, and distal to Lister's tubercle at this area is the scapholunate joint. I also assess the first dorsal compartment, which is here, at the site of de Quervain's tenosynovitis, and this is the area of tenderness where, should they have tenosynovitis, pain will be elicited. I also feel at the first carpometacarpal joint for signs of osteoarthritis. I feel the metacarpophalangeal joints, both in the fingers and in the thumb, the proximal interphalangeal joints, and the distal interphalangeal joints. I also feel for the flexor tendons in the fingers. These areas may show signs of pain if there is a tenosynovitis, and sometimes you can feel a nodule at the site of the A1 pulley, which is at the distal transverse crease of the palm. I would then do a quick screen of movement of the wrist and the hand. Then get the patient to perform various manoeuvres and copy myself. You put your wrist in this position, obtain full dorsiflexion, assess wrist flexion, then get the patient to put their arms by their side and assess supination and pronation. Then assess radial and ulnar deviation. This is radial deviation and ulnar deviation. The patient to make a clenched fist and an open arm, an open palm, and this will give you an idea of the cadence of the fingers. I would then, having assessed this, move on to more specialised tests. Having found where you think the pathology is, you should then direct your examination to either a neurological, a tendon, or a functional assessment. We'll start with the neurological assessment, starting then with the median nerve distribution. This is located on the radial border of the hand in the thumb, the index and the middle finger. You should therefore check sensation in the autonomous zone, which is the sensation over the tip of the index finger. You then assess power by assessing abductor pollicis brevis. You get the patient to keep their thumb abducted in this position and check the power of abductor pollicis brevis. You should then perform a direct compression test over the carpal tunnel. Any pain and pathology in the carpal tunnel will reproduce symptoms on the radial border of the hand by direct compression over the carpal tunnel area. This can be assessed again by Tinel's test, tapping over the carpal tunnel. Carpal tunnel syndrome can also be assessed by Phelan's test, maintaining the elbow in an extended position with wrist flexion will increase pressure in the carpal tunnel, and patient symptoms will be reproduced again in the median nerve distribution of the hand, and this position should be maintained for 1 minute to ensure that there either is or is no pathology in the carpal tunnel. The anterior interosseous nerve can be assessed by getting the patient to perform an O sign, ensuring that there is flexion at the flexor pollicis longus, the interphalangeal joint of the thumb, and the flexor digitorum profundus is working by providing flexion at the distal interphalangeal joint. If there is an anterior interosseous nerve palsy, the patient will perform a Kylo-Nevin sign, indicated by lack of flexion in the distal phalanx of the finger and the interphalangeal joint of the thumb. The ulnar nerve can be assessed, again starting with sensation in the autonomous zone, little finger. Power can be assessed by the intrinsic muscles of the hand, and you get the patient to abduct the fingers and you provide resistance and ensure that the abductors of the hand are working, indicating that there is no pathology in the ulnar nerve. Frohman's test can be assessed by asking the patient to hold a piece of card between their thumb and their hand, and the patient's arm supinated. Paper should be slid between the thumb and the hand, and the patient asked to keep the paper in this position. The ability to do so indicates that the adductor pollicis is working. Should this be incompetent, the patient will demonstrate flexion of the interphalangeal joint of the thumb, and the paper is retained by this means, indicating that the ulnar nerve is injured in some way. You should also assess the ulnar nerve, again working from proximal to distal. It should be assessed at the elbow by direct compression at the cubital tunnel behind the medial epicondyle. Tinel's test can be used here to assess for tingling in the distal ulnar nerve distribution. You should also perform a flexion test at the elbow, which will compress the ulnar nerve, and you should maintain the wrist in extension to ensure that the carpal tunnel syndrome symptoms aren't reproduced. And if this is positive, the patient will get tingling in the ulnar nerve distribution of the forearm and the hand. Distally, the ulnar nerve can be injured in the Guyon's canal. This is located between the hook of the hamate and the pisiform. Again, you can perform a direct compression test to reproduce pain and symptoms in the ulnar nerve distribution of the fingers, or a Tinel's test in this area. A high or a low ulnar nerve lesion can be elicited by assessing the sensation at the dorsum of the hand. The dorsal cutaneous branch is given off 5 cm proximal to the wrist. Therefore, if the injury occurs to the ulnar nerve at the wrist, the sensation to the dorsal ulnar aspect of the hand will be intact. The radial nerve can be assessed by the sensation to the first dorsal web space and the power by resisted wrist extension, feeling for the tone in the forearm. Function of the hand is assessed by a variety of different grips. A fine grip is assessed by asking the patient to pick up a coin. Tripod grip by asking them to write with a pen. Key pinch by asking them to use a key to open a door. Power grip by asking them to squeeze your fingers. And a hook grip by asking them to make a hook position and assess their degree of power. We then move on to a tendon assessment. I would advise checking each tendon in isolation. The thumb can be assessed by abductor pollicis longus, placing the thumb in abduction, and providing resistance. Abductor pollicis brevis by providing resistance in the proximal phalanx. Extensor pollicis longus by asking the patient to lift their thumb off the table. Extensor pollicis brevis by resisting the patient at the proximal phalanx and asking them again to provide extension. And flexor pollicis longus by asking them to flex at the interphalangeal joint of the thumb. The fingers can be assessed by examining the interossei. If you ask the patient to spread the fingers and stop you from pushing them together, the flexor digitorum profundus should be examined by holding the proximal interphalangeal joint in extension and asking them to bend the distal interphalangeal joint for each finger. And the flexor digitorum superficialis tendon can be assessed by holding the other fingers in extension and asking them to bend at the proximal interphalangeal joint. The extensors of each finger can be assessed by asking the patient to hold their fingers in extension. You can also see the extensors working nicely. The wrist extensors can be assessed by asking the patient to extend at the wrist, keeping their hand in a clenched position, and extend at the wrist, and resist forward flexion of the wrist while palpating extensor carpi radialis longus and brevis in the second dorsal compartment of the wrist. The extensor carpi ulnaris can be evaluated by asking the patient to resist wrist extension with ulnar deviation. The patient again in wrist extension, dorsiflex at the wrist and place it in ulnar deviation, and then get the patient to keep their arm in that position, palpating again over the extensor carpi ulnaris, ensuring it's intact. We can then move on to more specialised tests. Finkelstein's test can be assessed by palpating for pain over the first dorsal compartment, getting the patient to place their thumb in the palm, and moving the wrist into ulnar deviation, and this will reproduce the patient's symptoms in the first dorsal compartment, where they may have a diagnosis of de Quervain's tenovaginitis. Osteoarthritis at the first carpometacarpal joint can be elicited by the axial grind test. This is where the carpus is stabilised and the metacarpal of the thumb is axially ground against the trapezium, and this will elicit pain if there is first carpometacarpal osteoarthritis. The scapholunate ligament can be assessed by Kirk-Watson's test. If you have the patient with a flexed elbow, you palpate the pole of the scaphoid, which is just distal to ECR. You then place your finger over the proximal pole of the scaphoid and your thumb over the dorsum of the wrist, and you then deviate from the ulnar to the radial border of the hand, and you will feel the proximal pole of the scaphoid at the dorsum of the hand snapping back should the scapholunate ligament be incompetent. Allen's test can be assessed by occluding the radial and the ulnar arteries and asking the patient to make a fist twice. This empties the blood from the hand. You then release the ulnar artery and you should see the blood return to the hand. You then put your pressure over the ulnar artery again, ask the patient to make a fist twice, release the radial artery, and again you should see the flow of blood back to the hand. If this is incompetent in any way, it may demonstrate that there is insufficient blood supply from either the radial or the ulnar artery to the hand.
Let's go through just some standard memory tests, and what I want you to do is try to remember a few things, and I'll ask you again in a couple of minutes. First of all, just 3 words: Chevrolet, zebra, and honesty. What are they?
Chevrolet, zebra, and honesty.
Okay, and now 3 things around us in the room right now. That TV monitor that's right next to you there, the computer, my stopwatch, and this particular book. Okay? So what are the 3 things in the room?
TV, the stopwatch, and the book.
Okay, great. Try to remember the words and the things in the room, and I'll ask you again in just a couple of minutes. Okay. What day of the week is today?
Today's Saturday.
And what city are we in?
Boston.
And what is the date?
October 21st, is it? No, I'm sorry, November 21st.
Okay.
You wrote it down.
I did. I write down everything you say.
Look at my dates.
19.
Actually, I don't keep track of dates anymore.
Yeah.
I haven't had
Things
to.
have changed.
Yeah. 1998.
Okay. Sure. Okay. Now, who's our president now?
Clinton,
And who was president before him?
Reagan. I mean Bush.
Mhm.
Sorry.
No, that's okay. That's common for all
Very
of us.
common.
Very common for all of us to do. And then before him was
Reagan.
okay. And then just one before that. Who was that?
Carter.
Yeah. Okay. Good. Now, tell me some newsworthy events that are going on in the world today. What's going on that you know about?
That's a good question because I played golf for 2-3 days. I haven't been watching. Well, actually, kind of the hearings, presidential hearings.
Yeah.
It's been
Well,
going on.
what controversy or case was that about now?
Monica Lewinsky case.
Yeah. Okay.
The star hearings and debates. And,
Okay.
I guess for the impeachment hearings. That's what.
Very good. Now, what I want you to do is to spell world backwards.
DLROW.
Okay. Very good. Show me how you would use a comb to comb your hair. Okay. And how you would blow out a candle. Okay. Good. Now, what I want you to do is to take this page. I want you to draw the face of a clock. Make the circle big enough and put the numbers in. And then set the hands at 10 past 11.
I haven't had to do this for a long time. 10 past 11, you
10
said?
past 11. Perfect. All right. Now, say this after me. No ifs, ands, or buts.
No ifs, ands, or buts.
Okay. Now what I want you to do is to tell me those three things we pointed to in the room.
TV, the watch, and the book.
Okay. And the words before that?
Chevrolet, zebra, and honesty.
Okay. Very good. Now take this back and anywhere on here write any simple sentence, a complete sentence that you make up. It can be very simple. That's intended to be a three-dimensional drawing. Okay. So do a representation of a cube yourself. Let's say this is a map of the United States, okay? This whole page. Let's use a brand new one, okay? So if you just picture the whole United States fitting on this right now, put a C where California is, and F where Florida is. Okay, where's your hometown? And just put the initials for that. Okay. And where would Denver be? Example. Okay. And how about the Gulf of Mexico? Okay. Other mental status issues, that's pretty much all I would do right now in a screening examination. You've got geographical orientation, you've done memory, both for verbal and nonverbal or visual information. We've looked at historical information, we've looked at current events, we've looked at language skills. The only thing we would probe more deeply would be focused concentration and attention and mathematical skills and those sorts of things. And at least for right now, we won't be doing that on this level of testing. So it's worked out just fine. What you're able to do here, having seen you operate all day long, knowing that there aren't any problems, certainly adequate information for me. Things are working just fine.
Can you tell me whether you wear spectacles, please?
No.
No. Okay, I'd like you to read some print off here. Could you take that in your hand and cover up your right eye, please? Could you read the top line?
He moved forward a few steps. The house was so dark behind him, the world so dim and uncertain in front of him.
Okay. Could you swap eyes and hands now, please?
Then he heard a sniff, felt something warm against his leg. He had almost stepped upon the animal. He bent down and stroked its wet coat.
Okay, that's great. Thank you. Could you cover your right eye with your right hand, please? Now, I'd like you to look and concentrate in the centre of my eye. And I'm going to bring my finger in, and when the finger moves, I'd like you to say yes.
Yes. Yes.
When I'm doing this, I'm comparing the patient's visual field with my own.
Yes.
Okay. Could you swap eyes now, please?
Yes. 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 Yes.
What I'd like you to do, please, is to look behind me at the clock and focus on the clock and not look straight at the light. Please notice for doing this, I'm using the ophthalmoscope for examining the patient's right eye in my right hand, and I'm going to look into his right eye through my right eye. First of all, I'm going to examine the red reflex. I'm now going to move closer to examine the back of the eye. I'm looking at the optic disc, I'm looking at the vessels, and I'm now going to scan the rest of the retina. I'm now going to move to look in the left eye. I'm going to swap the ophthalmoscope into my left hand, and I'm going to examine the patient with my left eye, looking at his left eye. Again, if you could look into the distance, please. Again, check the red reflex, and then examine the back of the eye. What I'd like to do is get you to focus on the tip of my pen. I'd like you to follow with your eyes and keep your head still. I'd also like you to tell me if you see double at any position.
Right.
Okay. So if you could just follow my pen. I'm taking the patient's eye movements to the extremes of horizontal gaze first. I'm then examining vertical gaze. At all stages, I'm looking to see if there's any nystagmus in any particular position. I'm now going to test for the movements of the oblique muscles. Okay, so you didn't see double in any of those positions?
No.
As the eyes converge, both pupils are seen to constrict. I'm now going to test the sensation on your face. I'd like you to tell me if it feels the same on each side.
Yes. Yep. Yep.
Can you clench your teeth tight? Keep clenching. I can feel the temporalis muscle contracting. And again, please. I can feel the masseter contracting Can you open your jaw now, please? The pterygoid muscles open the jaw in the midline. Could you keep it open for me? The pterygoids are strong and I should not be able to overcome this movement. Can you move your jaw from side to side? If the right pterygoid muscle is weak, the jaw will deviate to the right, and if the left is weak, it will deviate to the left. Could you raise your eyebrows fully, please? And we're looking for wrinkling of the forehead due to contraction of the frontalis muscle, and this should be symmetrical. Can you now screw your eyes tight together? We're testing the orbicularis oculi muscle, and I shouldn't be able to open the eyes. Thank you. Now, can you smile like this, please? And I'm looking for symmetry of the smile and equal action of the orbicularis oris muscle. Now, can you blow out your cheeks? This is a function of the buccinator muscle. I press gently and see if there's any incontinence of air and escape of air from the mouth. Thank you. I'm going to cover one ear and whisper a number in the other. Would you tell me what the number is, please?
36.
Yeah.
43.
Thank you. I'm going to do some tuning fork tests. This is the Weber's test. Can you hear that vibrating?
Yes.
Does it sound louder on one side or the other?
It's the same on both sides.
That's normal. I'm now going to do the Rene test. Can you hear that vibrating?
Yes.
Please will you tell me when it stops?
I can't hear that.
Can you hear that?
Yep.
That's a normal Rene test. I would now go on to repeat the test on the opposite side. Could you open your mouth for me? Could you protrude your tongue? Can you move it from side to side? Now can you push your tongue against my fingers? And can you do it on the other side, please? Thank you. I'm going to test your neck and shoulders. Could you shrug your shoulders for me, please? I'm looking for symmetrical elevation of the shoulders by the trapezius muscles here. Next, could I get you to turn your head against my hand? And I'm looking here at the sternomastoid muscle. If we could do it the other side, please. Could you turn your head against my hand again? And again, we're looking at the sternomastoid muscle here. Okay, that's all I need to examine. Thank you.